Thank you all for coming. Marty Goldman. Controversies in cardiology this year has been really excellent, and tonight's going to be no exception. Just to tell you, the last visiting professor this calendar year will be next month with Marty Leon from Columbia, and we'll talk about asymptomatic aortic stenosis. Tonight's controversies and panel discussion is actually going to be on an oldie but goodie, talking about restrictive heart disease, particular focus on amyloid heart disease. And we're very lucky to have Jim Thomas from Northwestern here as our visiting professor, and Dr. Fuster will introduce him in more detail. Mohammed Al-Qazaz, who's the fellow, who will give an overview, had a very difficult task coming up with new information on an old topic. Mohammed.
Good evening, everyone. Thank you all for coming. So restrictive cardiomyopathy, as you all know, is responsible for 10 to 15% of heart failure with a preserved ejection fraction. This involves a wide range of infiltrative diseases. Cardiac amyloidosis is a great case example to show the complexity of infiltrative cardiomyopathy in diagnosis and management. It's caused by amyloid fibrils deposition, which may not or may be associated with involvement of other organs. The major protein precursors for amyloid that affect the heart are three: light chain immunoglobulin leading to primary AL amyloidosis, which is usually associated with neoplasms such as multiple myeloma or lymphoma; familial amyloidosis, which is caused most commonly by mutated transthyretin protein, and there are more than 200 mutations associated with that. It's more prevalent than we think. Valine 122 isoleucine mutation, for example, is a common cause for transthyretin mutation and amyloidosis, and is found in African Americans at a high prevalence of almost 4%, which can coexist with AL amyloidosis and even complicate the diagnosis process. Wild-type transthyretin amyloidosis, which is formerly known as senile amyloidosis, is the third type that affects the heart, and it occurs almost exclusively in elderly men. Amyloid deposits occur in the ventricle, atria, small vessels, especially perivascularly, in the valves. Regardless of the type of the amyloid cardiomyopathy presents with typical symptoms of dyspnea and right-sided heart failure. However, non-cardiac symptoms are as important because they might prompt early diagnosis of the cardiomyopathy which impacts prognosis and treatment. Microglossia or periorbital purpura are highly suggestive of AL amyloidosis over other types, and carpal tunnel syndrome precedes wild-type amyloidosis in 8 to 10 years. Although no single non-invasive test is pathognomonic for cardiac amyloidosis, many studies indicate that echocardiographic evidence of left ventricular wall thickening by atrial enlargement and increased echogenicity in conjunction with reduced electrocardiographic voltages is strongly suggestive of cardiac amyloid. Furthermore, new echocardiographic techniques such as strain imaging can demonstrate impairment in the longitudinal function. Usually it shows worse longitudinal strain in the mid and basal ventricle with relative sparing of the apex, with an apex to base ratio of longitudinal strain of 2.1, which is specific, before even ejection fraction becomes abnormal. Also, recent observational and case control studies suggest that magnetic resonance imaging yield characteristic findings of amyloidosis, such as diffuse and subendocardial late gadolinium enhancement of the left ventricle myocardium. And a technique called T1 mapping shows subendocardial T1 relaxation time that may be shortened in amyloidosis, and interestingly, the possibility of measuring extracellular volume expansion based on T1 mapping can be helpful. It may permit an early diagnosis of cardiac amyloidosis even before an overt left ventricular late gadolinium enhancement are found, and is possibly an early feature of cardiac involvement before and when compared to increased wall thickness. All these are offering promise for early detection. Another exciting imaging modality is nuclear imaging. Radioactive traces such as technetium pyrophosphate or technetium diphosphopropodicarboxylic acid with SPECT imaging is resurging, especially in Europe. These agents are helpful, especially in detecting transthyretin amyloidosis, and may be able to differentiate it from AL amyloidosis. The importance of this modality is high specificity for ATTR, cardiac amyloidosis, and the possibility of detection subclinical disease even before MRI. All these advances in imaging with the right clinical scenario and presentation can negate the need for biopsy, especially endomyocardial biopsy. Moreover, cardiac biomarkers such as troponin or BNPs are highly suggestive and help in risk stratification and prognosis of patients as shown in the revised Mayo Clinic scoring system. Management strategies for cardiac amyloid in general include stuff such as diuretics, but it's a tough balance because these patients are very sensitive to volume shifts and might have orthostatic hypotension, even syncope in the background of autonomic dysfunction that might suffer from. ACE inhibitors, beta blockers, or digoxin can be even harmful. Digoxin can bind to the amyloid fibrils directly and increase the risk for toxicity. ICD therapy for primary prevention in this population is controversial, as we'll discuss. The other cornerstone for treatment is based on aggressive targeting of the amyloid precursors. In AL amyloidosis, chemotherapy with or without autologous stem cell transplantation is the mainstay therapy, but many patients with cardiac involvement have worse prognosis peri-stem cell, and they get excluded, especially if they have NYHA class 3 or 4 or positive cardiac biomarkers. Cardiac transplantation is used less frequently, especially when there is extra cardiac involvement, but there are some trends toward change. Sequential heart and stem cell with high-dose chemotherapy has shown promise in younger patients with localized cardiac amyloidosis. Liver transplantation is the mainstream therapy for mutated transthyretin amyloidosis given the fact it was produced there, but it's not curative as it can reoccur as the wild type might dispose over the old mutated fibrils. Exciting stuff are the similar findings in recent phase 2 studies which indicate promising strategies to stable the native structures of the transthyretin proteins, such as tafamidis in ATTR patients, or small interfering RNA drugs that can silence the expression of mutations such as Valiant-30 methionine, such as rivacerin. Overall, there are many advances in diagnostic and therapeutic approaches to cardiac amyloidosis that might change the outlook of this disease and give new options to patients. Thank you.
Good job, Mohamed. Very good job, actually. On an entity that is not simple. There are about 5 different types, and you have summarized this very well. Well, it's a pleasure for me to introduce today Dr. James Thomas, who I had the fortune to meet him for the first time when I moved to the Mass General. It was in the early 1990s. And I have followed his career, which has been spectacular. At the present time, Jim is actually the director of the Center for Heart Valve Disease and Academic Affairs at Northwestern Medical Center in Chicago. Let me go back to his biography. First, he's the first person who puts the date of birth in a CV. I have not seen this for a long time, but today in the Google, everybody can learn how old we are. April 6, 1955. Is this all right? You don't mind? I don't mind. Okay. You have done very well over the years. He was born in Oklahoma City, and in 1977 he moved to Harvard Medical School, and then he did his internship and residency at the Mass General Hospital. Then for a year, in 1984, he became a fellow in cardiology at the University of Vermont, and then he went back to the Mass General Hospital, where he got a staff position, and this was actually in 1986, instructor and assistant professor of medicine, and actually was in 1992 when he moved as a director of cardiovascular imaging at the Cleveland Clinic, where he became professor of medicine at the Ohio State University School of Medicine, and then eventually professor of medicine and biomedical engineering. Now, was in 2014 when he finally, 2 years ago, he moved to Chicago with, as I mentioned, professor of medicine at the Feinberg School of Medicine at Northwestern and director of the Heart Valve Program and Director of Academic Affairs. Now, he has numerous accomplishments. If we start with the awards, he began winning one of these paper poster competitions at American College. He was in the final of the Young Investigators Award of the American College in 1988, first prize of the American Society of Echocardiography Research Competition 1990, the Richard Popp Excellence in Teaching Award, the American Society of Echocardiography, and also the Adler Lecture of the same organization. Over the years, he has been part of many committees of interest, of importance, and more recently, Cardiovascular Board Examination Board at the American Board of Internal Medicine, Chairman of the Writing Group for the American College of Cardiology Training, a statement of multimodality cardiovascular imaging. That's where it came from, this famous multimodality. You were the one who set this up. We'll have a talk, you and I, later on. Anyway, this is, he has been very instrumental. Certainly in the American Society of Cardiology, he was the chair of the industry roundtable, was president of the American Society of Echocardiography in 2011, 2012, and chair of the American Society of Echocardiography International Committee. So he's in the editorial board of the top journals, of course. I don't mention the number one, but I will mention number two, Circulation Research, a Journal of American Society of Echocardiography, Heart, and so forth. Now, he has very well funded over the years. Actually, I counted about 50 projects that he has been part of as PI, co-PI, or NIH from the American Heart Association and from many other organizations. So in terms of productivity, from the point of view of bibliography, he has 700 papers, all within the issue of imaging, but really addressing all the cardiovascular disease entities that I know. He has been involved with everything. And it's interesting how he got into that, because his first paper is quite interesting. It's entitled 1985, Gypsies and American Medical Care. Can you give us a follow-up? Anyway, look, a very accomplished individual. We are very lucky to have him today on a subject that is difficult, and is a subject that goes beyond the echocardiographers, as you will see. So thank you very much for visiting us, and I'm going to give you to remember this visit, James. All right, here is the plaque that we give to you on behalf of the organization and for outstanding teaching. Anandi Sharma, visiting professor, is the father of Dr. Sharma here, and the Simon Dack Memorial Lecture, May 23rd, 2016. Okay?
Thank you so much. Wonderful.
You can sit there in the middle. All right, so I'm going to ask the panelists. Martin Goldman is going to be the one who's going to direct this whole panel discussion. Peter Gorbik, Peter, you're there. Steve Liao, Mark Miller, Sean Pinney, and myself. All right?
And Mohammed.
Well, of course, he's the protagonist. Why the fellow always goes there?
So the first question we usually give to the visiting professor. So will Oklahoma City beat the Warriors in the NBA division finals? Yes or no? Yes or no?
Yes.
Okay.
Yes.
Jim, if you heard, was from Oklahoma City. Jim is from Oklahoma City originally.
Go on to crush LeBron.
And that's his former hometown, Cleveland, so that's sort of...
I've got so many teams I could root for between the Celtics and the Cavs, the Bulls, we don't talk about too much right now.
Let me just formally introduce the panel. Dr. Valentin Fuster, Physician and Chief Director of Mount Sinai Heart, Director of the Cardiovascular Institute, and Editor of JACC. Peter Gorovic, who's Professor of Medicine Rheumatology. Sean Pinney, Director of Heart Failure Transplantation, Director of Advanced Heart Failure and Cardiac Transplant Program. Mark Miller, Assistant Professor, Cardiac Arrhythmias Service, one of my good friends. Steve Liao, another good friend, Assistant Professor of Medicine and Radiology, Steve. And of course, Mohammed, who did a great job. We'll try to keep this sort of clinically oriented, because that's who we see as, when we're doctors in the office, and these patients are sometimes very problematic and sometimes mimic many different diseases. So if we start off with a 65-year-old patient a gentleman complaining of dyspnea for a few months. He has a history of hypertension, a mild overweight, mildly forgetful, and his echo shows some LVH, wall thickness around 13, good systolic function. EKG is mild LVH with a mild first-degree AV block. And he's coming to see you, Dr. Fuster.
Well, the first thing that comes to mind is whether the patient has hypertensive heart disease. Because the figures that you gave, if you start thinking on amyloid just from the beginning, I think is the wrong track. He might have amyloid, but I don't think this is the first way I would approach this patient. So if it is the LVH, is concentric LVH, the septum is normal?
Yeah.
All right. I would say most likely, at least by frequency, should be hypertensive heart disease.
Are you seeing patients with preserved ejection fraction, heart failure coming more often? Is this a growing entity?
Well, I think more than a growing entity, I think our knowledge grew because what happened is that we didn't realize that this was so common until, the data evolving from imaging studies, the evolution of cardiac failure groups. Now it's becoming obvious that 50% of patients with cardiac failure have restrictive disease. But I think I want to make one point, maybe Dr. Penny will correct me. From this 50%, there is only 15 to 20% that have the diseases that we are talking about. All the rest is hypertensive heart disease, diabetes, and so forth. So we should not be confusing what we are talking today with the entities that are very, very prevalent in restrictive disease and cardiac failure, hypertension and diabetes particularly.
Jim, is there anything on that patient's echo that would trigger a concern or more of a workup?
Well, yeah, I agree with Dr. Fuster that, as presented, overwhelmingly, this is a guy with hypertensive heart disease. I'd, check a hemoglobin A1C and, just the usual stuff and how overweight is overweight and all of that. But I think there are clues on the echo that automatically, after you've read a few million of these, come to mind. And one is to recognize the nature of the myocardium. This is not a perfect distinguishing feature, but there is something about kind of the sparkly nature of the myocardium and amyloid, so I'm always tuned into that a little bit. I read an echo the other day. It was a 94-year-old man whose history was until he turned 90, he was swimming 20 laps a day in a 25-meter pool. So reasonably good health and now was short of breath and was being sent because they thought he had coronary disease. Now, if you make it to 90 swimming laps and you don't have manifest coronary disease by then, you probably don't suddenly develop it. So I was already a little suspicious, and one look at the echo, it just sang out amyloid. It just looked a little sparkly. It was decreased systolic function, severe diastolic function, and then I'm sure we'll get into the strain pattern, and I think that is becoming the quickest path to glory with amyloidosis, because it is so easy to do in a modern echo lab, and it is so predictive that it really should be applied very broadly in patients with thickened LV walls.
So just go back a second. You mentioned about the sparkling or ground glass. With current technology and our harmonic imaging, is it as distinctive as it sort of used to be with fundamental imaging?
Well, it's different. I mean, the harmonic imaging gives you sort of generates some sparkles of its own. It highlights some of those inhomogeneities. So we've had to kind of recalibrate our eyes to how the myocardium looks. And I don't know that I've ever seen a good paper that has sort of blinded reviews of how sparkly this myocardium is. It's a little bit like the old definition of pornography. You know it when you see it. And this guy, the 94-year-old guy, when I saw it, I knew it. And I don't have a diagnosis yet, but I'm pretty sure that's what he's got there. But it is, and you're right, the machines have gotten better and better, and with higher frequency imaging, you do see a lot more detail in the myocardium there. But I think there is still something a little distinctive about the look of an amyloid.
So we'll get to strain in a few minutes. Dr. Gorovic, one of the issues are when you see these patients, it's pretty late in the disease, and it's pretty hard to know how long they've had it. So the question comes up because heart failure with preserved ejection fraction is something we're seeing more often now. What in those patients, if anything, should maybe flash the red light to say that patient should get a little bit more detailed imaging? Is there anything clinically in that history of a patient with mild hypertension, mild LVH? Should we be looking earlier for unusual things?
Well, the main issue, I would not have been thinking about amyloid based on what you're talking about, because it sounds more like hypertensive heart disease. For me, always one of the tip-offs for amyloid is if the right ventricle is involved as much as you see with the left ventricle, and that would be something that I'd be looking for. The other things with regard to amyloid would be whether there's any extra cardiac manifestations that should be paid attention to. We'll probably come back to the neuropathy again, because I think you outlined that. And then we always ask about a family history, particularly in someone who's relatively young. You know more about this than I do, but my understanding from what I've read is that the typical echo findings, the sparkling myocardium, is something that represents relatively late disease. So I don't know how often you miss that in a patient who you pick up relatively quickly.
So let's go to a second case, and that patient who was dealt with pretty easily with the yes, Sean.
So before you leave that case, I just want to make one teaching point, which is that you have to look at the echo and then you have to look at the EKG. And so the clue to a diagnosis, if you're going to chase zebras, and I agree with all the comments, everything is just screaming hypertensive heart disease. But if you're going to chase a zebra, then look at the EKG and look at the echo. If the echo shows a lot of LVH, then you would expect to see a lot of voltage on the EKG. If you don't see a lot of voltage, if you see low voltage, if you see a pseudoinfarct pattern, then you can start thinking of amyloid.
I think you're completely correct, but I think he mentioned the EKG was just LVH.
Mild LVH.
Because that's a critical issue, as you mentioned, but he commented on.
Mark, do you want to make a comment on what percentage of time would you see abnormal EKGs in amyloid, and what time sort of what Sean is referring to is sort of inappropriate voltage, maybe mild voltage, but inappropriate for what you'd expect in the mass? Is that more common, what you see in patients with amyloid?
I think you see it most commonly, right? Low voltage on the cure. It's actually interesting that sometimes as we're kind of reading EKGs, we'll come across individual ECGs that clearly are quite low voltage, and you go into the EPIC, you look at the medical history, and a lot of these patients already carry a diagnosis of amyloid, and sometimes they don't, and sometimes you reach out to the cardiologist and ask them to at least consider it. There's obviously many other explanations, but sometimes you can just see the BMI is not, patient's not overweight, there's no pericardial effusion, and patient comes in with low voltage and AF on the ECG, it's awfully suspicious.
So 62-year-old male, probably several month history of dyspnea on exertion and lower extremity edema. He had been having a weight loss, some abdominal pain, and some painless paresthesias in his lower extremities, erectile dysfunction, and some abdominal bloating. And his EKG, his blood pressure was 95/60. His heart rate was 52. He had some jugular venous distension. He had edema. Heart sounds weren't very distinct. And he had mild hepatomegaly. Dr. Fuster?
Well, bad news. You describe the right-sided problem. You describe a neurological involvement. You describe liver involvement, could be congestion, but could be something else. So this is a case that in heart failure, that you think about either an AL type of amyloid or the the TTR amyloid, which is the genetic one, because the other TTR, not genetic, only affects the heart. This is a systemic disease, so these are one of the two possible entities that I would be thinking of.
Mohammed, is there anything distinct on the physical exam that people should be highlighted, which could be a clue to amyloid?
So as Dr. Fuster pointed out, that this patient kind of has right-sided heart failure symptoms, which is a common finding in restrictive cardiomyopathy overall, and particularly in amyloid cardiomyopathy, regardless of the type of the amyloid, as heart failure symptoms. And in addition to that, as pointed out earlier, the non-cardiac symptoms sometimes can give you a clue to which kind of type of amyloid you have. AL amyloidosis being the most common cause of systemic amyloidosis can have a lot of extracardiac stuff. Only 5% of AL amyloidosis will present with pure cardiac symptoms without anything extracardiac. So the majority will have some sort of something extracardiac. So one of them is the neurological symptoms, from autonomic dysfunction, whether it is orthostatic hypotension or, as you mentioned, erectile dysfunction, or anything that suggests autonomic dysfunction, or peripheral neuropathy, anything of that sort. Or sometimes, most commonly, this patient will have small pericardial effusions, small bilateral pleural effusions that can suggest that. In addition to that, they can have like tooth indentations, dysphonias, and something very specific to AL amyloidosis is microglossia, which is like soft tissue infiltration as a in addition to periorbital purpura, which is like from the vascular involvement, perivascular involvement, which is highly specific for AL amyloidosis. It's almost pathognomonic, but no one says that directly. In non-AL amyloidosis, which are, as Dr. Fuster was pointing out, the wild type and the mutated transthyretin amyloidosis. In the wild type, not the mutated one, which is commonly in elderly men, it's mainly cardiac. The only clue is that bilateral carpal tunnel syndrome or carpal tunnel syndrome that happens kind of 10 years prior to that, secondary to amyloid infiltration. And lastly, in a mutated transthyretin is the early age, which usually can have peripheral neuropathy, and based on what kind of mutation you can have only cardiac involvement or extracardiac involvement.
Right, so save some questions for me there, okay. So Jim, his echocardiogram shows moderate hypertrophy. And you raised before about, he had Doppler abnormalities consistent with decreased diastolic compliance. Tell us a little bit about strain findings and what's unique and distinct and why strain has made a difference in the diagnosis.
All right, well, first of all, just to remind people what we're talking about when we're saying strain. Strain is just a dimensionless change of length of some structure. So if you have a rubber band that's 10 centimeters long and you stretch it to 11, that's a 10% strain. If you shorten it to 9 centimeters, that's a minus 10% strain. And so we're typically looking at the heart from the apex, and we're most commonly looking at longitudinal motion. And because the heart shortens base to apex during systole, longitudinal strain is a negative number. So minus 20 is a very typical normal value for the myocardium there. Now, the ways you do this in the echo lab, 15 years ago, we were doing this with tissue Doppler. It was a true labor of love. It was a very challenging, noisy, unloved tool that was really only a research tool. But beginning about, now it's about 12, 13 years ago, it was recognized that there are little speckles within the myocardium. These aren't amyloid speckles. These are little structures, and they're not real structures. They're actually interference patterns. They come from structures within the myocardium that are smaller than a wavelength of sound, some of which interfere constructively, some of which interfere destructively. So you have these little speckles there, and they tend to move with the myocardium. They are fairly constant in nature there, and so you can track them from frame to frame. And some very clever engineer figured out a way to look at frame 1 of an echocardiogram and then frame 2 of the echocardiogram and pattern match the speckles to see where they move from one frame to the next. and tell whether they are getting closer together or farther apart. And if they get closer together, that's a negative strain, and it will track this frame by frame through the cardiac cycle. So we look at global longitudinal strain, which is an average of the three apical views, apical 4, 2, and long axis. So it's the whole endocardium there basically averaged, and normal value is -20, and this is the number that we pay attention to in cardio-oncology. And if we see that suddenly decrease to -17 or -16, then we worry that there's some subclinical damage coming from the chemotherapy. The other way of looking at this is not as a global number, but as a pattern. And you can actually track out, say, 18 segments around the ventricle there and look at the strain in each one of these, and these can be color-coded into little bullseyes. And the typical normal pattern is a red uniform bullseye pattern there. If you have an LAD infarct, you'd have some light pink and blue down in the apex where there's dyskinesis, and you can very quickly localize infarcts by looking at these strain patterns. So in amyloidosis, it's sort of, I don't know that we even today have a real good explanation for exactly why this is, and this is, I had several of the fellows sort of say, well, how do we do things academically when we have to be so busy clinically? And so I'll tell you how this observation occurred, and it was about 4 or 5 years ago. One of our advanced imaging fellows, Dermot Phelan, and I were in reading echoes on a Saturday morning. We pulled the weekend duty that day, and we were looking at echoes, and there was a patient with amyloidosis, and our sonographers were getting engaged in strain mapping, so they had a nice strain map, and we saw kind of an unusual pattern, which was very light pink with a bright pink at the apex. And we said, that's interesting. And then it turned out like a few patients later on, we saw another patient with amyloidosis, same pattern. And sort of the light bulb went on over Dermot, and he said, well, let's look at a series of these. And we had enough patients we could go back to and analyze retrospectively that very quickly we could bring together a pretty good paper that we got into Heart and demonstrated the key finding is, it's called apical sparing in amyloidosis. And what you look for is if the average strain of the apex, all the apical segments, is twice the average of the rest of the heart, that has a very strong sensitivity and specificity for being amyloid. And it's a very easy thing to do in even a busy echo lab. You can, with the right equipment, you can do this in maybe an extra minute or so of the sonographer time. They'll show you this map. And many times it has been the only clue that there's something going on, and it really can be a way of addressing this sooner than we might otherwise.
So if this person had this unusual pattern, would the next step getting, Dr. Gorovic, would the next step getting an MR? Would that be the next thing that you would do, magnetic resonance imaging?
I think the next step now is doing a cardiac MRI, but we may get to the point of talking about nuclear imaging for heart. I found what you just said very interesting because we have very little information about the anatomic distribution of the amyloid, and I think it's interesting that there's this apical sparing, if that's what you're talking about. And I wonder, I really don't know why that should be. I mean, we know the amyloid, the deposition pattern for AL and for TTR is a little bit different, one from the other, what you see morphologically, but they both have this subendocardial enhancement, which I guess we'll talk about when we get to the cardiac MRI. But I don't know why that should be in terms of the physiology of the heart, why that.
I'll ask Steve to explain the answer. So first, maybe just explain to us the two modalities which are spoken about, a late gadolinium enhancement and the T1 imaging with or without contrast. So maybe just explain again in layman's terms a little bit about what we're looking at with those modalities.
Sure. Oh, sorry. So for MRI, I mean, the basic principle is that you have a very strong magnet, and the patient gets put into the bore. and the magnetic field is linear, and so all the protons line up in one direction, and then radio frequency pulses and different sequences are used to transfer the magnetization from the longitudinal to a transverse from from the Z to the XY plane. And then that's how images can be acquired. And different tissues have different characteristics that can be unmasked when they're exposed to these different radio frequency pulses and placed in the magnet. And the one that's most studied in amyloid patients is T1 relaxation or longitudinal relaxation. And different tissues based upon the cellular content, protein, collagen, things like that, have different T1 relaxation times. So myocardium, depending on the strength of the magnetic field, most commonly it's either a 1.5 Tesla or a 3 Tesla magnet, tends to be between 950 to 1,000 milliseconds, and that's before contrast. And then a lot of the research that has come out about amyloid has to do with not only pre-contrast, but also post-contrast imaging. And so the contrast that we use with MRI is gadolinium, and gadolinium shortens T1 time, or the inversion time, longitudinal time. And so based upon how much gadolinium is present, the T1 time can change at the time of imaging. And the most common application, aside from amyloid, that we use this for is late gadolinium enhancement is in the presence of ischemia or scar detection. And that's probably the most common reason why we use late gadolinium enhancement. But for the purposes of amyloid, we would expect a non-coronary distribution for late gadolinium enhancement. And so we would expect to see the subendocardium, as you said. And then as the disease progresses, we can also see transmural enhancement, or enhancement of the entire thickness of the myocardium. We get a lot of information from the MR in addition to T1 and late gadolinium enhancement. For example, we can see if the IVC is dilated. You can see if there's pleural fusion. And then with Cine SSFP, Cine gated images, we can see the thickness of the myocardium as well. Certainly our spatial resolution is better than echo, but echo's temporal resolution is still better than MR. And then we can also see secondary findings like enlargement of the atria, which you can also see with echo. But a lot of work that Mohammed highlighted in his talk has been done with gadolinium contrast kinetics, and specifically using a sequence called phase-sensitive inversion recovery, which can be used to figure out how much extracellular volume is in the myocardium. And so the thought process now is that the extracellular volume will increase before you see even potentially late gadolinium enhancement. And with T1 mapping, you can detect how much of the extracellular volume is expanded. And so normal extracellular volume is about 25% or so. And then as it becomes more abnormal, which you can also see in diabetic cardiomyopathies and hypertensive cardiomyopathies, but with amyloid, as that percentage increases, the paper that Mohammed mentioned in his talk seems to suggest that it correlates with prognosis. And so increasing extracellular volume, subendocardial late gadolinium enhancement, and then transmural seems to be the progression based upon MRI in terms of severity.
So are we looking at the same process? Because amyloid is a diffuse infiltration, but we're getting specific patterns of subendocardial, and then we're getting apical sparing. Do you want to take a hit at that, Jim? What are we looking at? Why aren't we getting, there's one paper which said that it was only, that apical sparing was only seen around a half of the patients, not all the patients. But that's a different distribution than we know pathologically, where it doesn't necessarily spare the apex. Is it just less myocardium, so therefore at the apex, which is normally thinner, there's less muscle, so relative less room for infiltration?
I don't think we have a good explanation right now. When we were putting that paper together, we went to our pathologists and said, can you help us explain this? And they weren't systematically looking at different areas of the heart. They would take a little biopsy or a little piece of it, and that was it. Our MRI colleagues were not much help at that time because the amyloid is, I guess, without the gadolinium, it's a very tough thing to null out when you give the gadolinium, and so they couldn't say, yeah, there's less amyloid going on at the apex. So we sort of reported it as a phenomenon. I will say one thing that always kind of concerned me was, is this a common feature of all storage diseases, you know, galactosidase storage diseases and things like that? And there was a very interesting paper out a couple of, maybe last year, from Frank Wiedemann's group in Germany, looking at a group of patients with Friedreich's ataxia and Fabry's disease, which on 2D imaging looked very similar to amyloidosis. And they did not show the apical sparing. They just showed sort of global reduction in strain. So it isn't simply like a geometric effect or something like that. There seems to be something about how the disease affects the apex that is different there, but I don't have a good explanation for what that is.
So if you have strong clinical suspicion and the echo looks, you know, normal with mild LVH but normal strain pattern, can we still get abnormal MR, Steve?
Say that question one more time.
So a person has a relatively normal strain pattern, mild decrease, but not that apical sparing. Can we, in just mild LVH, can we still get an abnormal MR?
Yeah, the studies that they published, particularly this one with the contrast kinetics, seems to suggest that you can have increasing extracellular volume even before you have significant LVH detected by echo or by MRI.
So if your clinical suspicion is high, even if the echo looks fairly normal, the MR would still be helpful.
I would say so, yeah.
Dr. Pinney, the use of biomarkers in this disease, you know, are you using that both from a diagnostic as well as to follow the patients clinically?
Not so much from a diagnostic viewpoint, but more of a prognostic viewpoint. So if you have elevated levels of natriuretic peptide, elevated levels of troponin, those, there are various scoring systems, you know, all of them go 1 to 4. You can use that to then prognosticate, predominantly in AL amyloid, what you can figure out what the survival is going to be. So those people with the most advanced levels of natriuretic peptide elevation tend to have a median survival of about a year, anywhere from 4 months to a year. Those people who have lower levels of natriuretic peptides, a little bit better survival.
Mark, if you have this patient with evidence of an abnormal echo and an abnormal MR, is that of a concern? Should you halter? Should you do an electrophysiological test to see if there's conduction abnormality, if they're at risk for AV dissociation?
I don't think you need to do prophylactic testing for AV conduction disease. I mean, a lot of these patients actually have some evidence of AV conduction disease, but I don't think an AP study is necessarily predictive of their risk for bradyarrhythmias. I think the bigger question is, what do you do with the patient who has evidence of cardiac amyloid and has, let's say, preserved LV function, and do you consider the implantation of a prophylactic defibrillator? It's one of the few patient populations where we actually consider defibrillators with preserved LV function. And I don't think anyone quite knows what to do. I know there's the Stanford group has put out like their own algorithm about what to do with these patients, and they feel that, you know, if they've had an episode of syncope, you should consider it syncope that's clearly not positional or vasovagal or the other type of syncopal episodes that they're prone to, that you should consider implantation of prophylactic defibrillator, or if they have a high burden non-sustained VT, because we know that that correlates to some degree with their risk of sudden cardiac death. But that's a somewhat aggressive approach, and you have to keep in mind that a lot of these patients, even when they have defibrillators, even when they have VT or VF, they still end up dying of electrical mechanical dissociation anyways. So it's not necessarily, we don't know if defibrillators extend their lives. It's all based on small case series and, you know, tertiary care centers.
So if this patient had syncope, and we don't know whether that's orthostatic hypotension or an arrhythmia, would you put in a prophylactic device for that patient? Would you put in implantable device to be able to tell whether they get arrhythmias in the future or not wait for another one?
Well, I think the issue is if you don't know what the cause of the syncope is, then you probably have at least some justification for putting in a defibrillator. But like I said, I think that's relatively aggressive, and we don't have any risk stratification tools for this patient population that's clearly at risk for sudden cardiac death. It's unfortunate, but it's a relatively small patient population, hasn't been well studied. The idea of putting in implantable loop recorders in these patients is interesting from a research perspective more than anything else, but if they have small episodes of non-sustained VT, is that going to be what pushes you to put in a defibrillator? I don't know. It would be interesting to see what their overall burden of arrhythmias is, both from an atrial and a ventricular standpoint. We know they have a high burden of AFib, and a lot of it is silent. A lot of it probably results in heart failure hospitalizations, and obviously they're at high risk for stroke. So I don't think anyone has actually looked at this systematically, although I'm sure somebody is.
So if they had atrial fibrillation, right, would you anticoagulate with a NOAC?
I think all amyloid patients should be anticoagulated with a history of atrial fibrillation. Their risk of stroke is clearly higher than the general population with AFib.
So NOACs are okay, or we don't know enough?
We don't know. I use them, but we don't know if it's okay.
So Dr. Gorovic, if in this patient with dyspnea, edema, echo, and the nuclear are very suspicious for amyloid, do we need tissue typing to know the type of amyloid this patient has, and where would you get the tissue from?
Well, I wanted to comment on one thing. With regard to the orthostasis, there are 3 reasons why a patient with amyloid will have orthostasis. One will be that they might be volume depleted. One might be that they have autonomic neuropathy. So that's very important. This patient did have paresthesias. And the third is that the patient may have amyloid angiopathy. And that may be something worthwhile thinking about, because I was thinking about the fact that certainly with AL amyloid, you see a lot of congophilic angiopathy. And I wonder whether that might be relevant to the heart and the apical sparing. I don't know. That would be one thought. In terms of trying to make a diagnosis, the diagnosis of amyloid rests on tissue. But there is a very interesting position paper in Circulation that just appeared, which is a coordinate study from a number of amyloid groups, which are essentially saying that if you see uptake on technetium pyrophosphate scanning and cardiac MRI, you don't need to do a biopsy. That would be enough to make a diagnosis and make some decisions about treating it. But if you did need a biopsy, the major alternatives would be to biopsy another organ that's involved. What we do here routinely, because we set it up as a protocol, is that we do abdominal fat pad biopsies, which are significantly positive in maybe as much as 70 to 80% of the time. And we have a protocol here, which is done with the dermatopathology department, where if we get a positive, we send it to the Mayo Clinic for typing. So we can actually tell you from an abdominal fat biopsy whether it is amyloid and what type of amyloid it is. And then we make the decision.
Do you routinely in these patients send off serum and urine immunoelectrophoresis?
It's a standard to do it, but we have to be very careful about this, because in the TTR amyloid, and I think you've referenced this in your manuscript, is that about maybe 15 to 20% of them will have monoclonal immunoglobulins or immunoglobulin light chain and still be TTR. So it's a little bit deceiving, although that is certainly something that we do.
Sean, are you doing cardiac biopsies, or they're not asking really for cardiac biopsies anymore, getting the peripheral tissues are adequate?
No, we do a lot of cardiac biopsy for amyloid. I would say we do at least 1 a month to rule in or rule out amyloid. We don't do a lot of the fat pad biopsies because, as Dr. Gorovic said, the sensitivity, specificity, the sensitivity is only about 60%. Specificity is much higher, but the sensitivity is only about 60% or so. And because we're a heart transplant center, we do lots of biopsies, so we can safely do a biopsy with less than 1% risk of perforation. So our preference would be to biopsy and confirm the findings that we find on imaging. We haven't yet started with the technetium imaging, but I think that's going to be a useful part in the algorithm. So if you do a technetium scan and you don't see any enhancement, any uptake, then you can be pretty sure that they don't have ATTR amyloid.
Yeah, Dr. Fuster.
Yeah, somebody mentioned technetium radioisotope. My understanding is only diagnostic for the TTR type. In fact, if you want to distinguish between the AL amyloid and the TTR, there is no better test than the use of technetium. And this is something that we should use more and more, aside of protein electrophoresis that you mentioned. The other issue is obviously it's common sense, but we see so many patients that still we don't know if they have constrictive pericarditis. I don't want to get into the field because you are very directed to the amyloid, but just to make a comment.
I was going to ask Dr. Pinney, routinely you're doing a right and left heart on those people, and the biopsy you're doing from the left or the right, and you're ruling out constriction in the appropriate cases, I presume.
We'll do a left heart cath if there's a question of constriction, but mostly we're doing right heart cath, predominantly from the neck with an endomyocardial biopsy performed through the neck, with a biopsy through the neck. If we do have a case where we're not certain about the diagnosis and there's the potential for pericardial constriction, we'll do left-sided and do simultaneous RV-LV measurements to see if there's concordance and discordance. And happy to go through what all the fellows fear, which is how do you tell the difference between, constriction, restriction, but I'll leave that up to you, Marty, if you want to go there or not.
Mark, so in this patient,
I'll explain it, don't worry.
all right, so Mark leaves the patient alone. Dr. Pinney, are you concerned about the typical heart failure medications in treating this patient who has peripheral edema, shortness of breath, dyspnea, pressures running around 100, heart rates in the 50s?
Absolutely. So a couple points to be made. So the first is, we'll just throw it out there, don't use digoxin. Digoxin can bind to the amyloid and you can actually get dig toxic in the heart, so it's very pro-arrhythmogenic in patients with cardiac amyloid. Patients with cardiac amyloid have diastolic dysfunction that we're talking about, but they also have systolic dysfunction, not only in the ventricles, but also in the atria. And I completely agree with Mark's comment earlier that patients who have AFib, but even those who don't have AFib, you should consider anticoagulating them. So if you look on the echo and you don't see the atria contracting, that would be someone I would consider anticoagulating. Because of the fact that they have systolic dysfunction, I tend not to use beta blockers. This is not neurohormonal activation that you're trying to block with a beta blocker to prevent disease progression. This is an actual infiltrative cardiomyopathy that's poisoning the ventricle. So I'm not really sure that there's a role for beta blockers unless you want to use it for an antiarrhythmic effect. They are frequently bradycardic, and it can certainly enhance the bradycardia and the hypotension, so I tend not to use it. I have one woman who I just saw today who has AL amyloid, and she had non-sustained, very ugly-looking non-sustained VT, so I have her on a beta blocker, and she's been doing okay with that. Judicious use of diuretics to control volume status, and as Peter said, when you have hypotension, it's frequently due to overdiuresis, and I think it's critical to understand what happens in these hearts where the end-diastolic pressure-volume relationship gets shifted up and to the left. What that essentially means is that you fill at a higher pressure with a lower volume, intracardiac volume. So to put it the other way around, if you want to try to diurese someone and you do what I frequently instruct, which is to follow the neck veins, if you're having someone who has true restrictive cardiomyopathy, really advanced amyloid, and you get them dry to the point where you don't see jugular venous distension, they're going to be on the ground. And that's because they need a higher pressure to make sure that they have an equivalent amount of volume.
Just one thing that wasn't mentioned, I think that it's very, if you have a patient with amyloid and newly diagnosed AFib, especially if they're being hospitalized for heart failure, I think you have to be relatively aggressive about getting those patients back in sinus rhythm, however you want to do it, whether you're wanting to do it with cardioversion and antiarrhythmics or ablation. I think those are the patients that probably benefit the most from being in sinus rhythm, and I wouldn't wait 6 to 12 months before the horse is already out of the barn.
Amiodarone okay in those patients?
Yeah, I mean, we use it not infrequently. Unfortunately, a lot of them have some kidney disease, so there's not a lot of options in these patients, but we do use it, and if the patient does not have class 4 heart failure, if they have preserved LV function, and they can tolerate a procedure, then there's no reason they can't be considered for an ablation. I think that obviously the success rate of the procedure is different than just a straight, paroxysmal patient, but that doesn't mean they shouldn't be offered the option of durable rhythm control.
Dr. Fuster, I want to ask you a theoretical question. We know in patients with AL amyloid, their walls are not necessarily as thick as patients with transthyretin in which the walls can get much thicker. And so it's thought that transthyretin is truly an infiltrative disease where AL may actually be some toxicity from the light chain. We see amyloid in the brain, and there's a whole issue now about imaging amyloid, where it appears to be totally different. And going through all the different major types, we don't have sort of a cross-reaction between amyloid systemically, even in the same type of amyloid deposits in the brain, which have been detected as an early marker in patients with Alzheimer's. How are those amyloid
Well,
different?
this is a paper in JACC, actually, published in the last maybe 5 or 7 weeks, in which for the first time the beta amyloid of the Alzheimer's has been identified in the heart. And the question is how this is pulled together. This is a very interesting paper because no attention has been paid to the question, but now they are beginning to look at. So we have to, I think it's important to understand what amyloid is about, because basically are normal proteins that they get split, and then there is a component that gets conjugated, and then you have the fibrils. But the number of proteins that can do this are numerous. And the question is, now people are beginning to understand the chemistry of all of these, and who knows if we are going to begin to look at Alzheimer's together with amyloid of the heart. This has not been done, surprisingly. But I think your question is beginning to be addressed, actually.
Dr. Gorovic?
My very first grant was looking at senile cardiac amyloid. It was a grant I got from the VA hospital, and I was collecting autopsy material and looking to see the incidence of Alzheimer's disease, cardiac amyloid, and the third one is the type that occurs in the pancreas. And what I can tell you is that there's no correlation at all, that they really have separate issues. But Dr. Fuster is entirely correct. There was a wonderful review article in the New England Journal about 3-4 years ago, which was entitled Alzheimer's Disease in the Heart. And they were trying to make exactly this correlation, that this is an aggregation disorder, and that we now are up to about 30 different aggregation disorders. They follow certain patterns, and so understanding each one of them is basically, I think, going to mold our approach to therapy, which at this point, as you know, is very limited, but there are a lot of interesting possibilities. The same sort of therapies that people are thinking about with regard to Alzheimer's disease, and we have a very large Alzheimer's center here, as you know. They're very interested in therapeutics. The same sort of approaches, I think, are very, very applicable to the cardiac amyloidoses.
I have to make a comment here. TTR amyloid, the senile amyloid, occurs in 30 to 40% of people at autopsy. It has not been done, actually the discussion of that paper, there is no pathological study that has correlated the pathology of the heart with Alzheimer's. So to talk clinically is very superficial at this moment, because amyloid is so common to have in the heart. And the question is whether that amyloid, which is the TTR, has something to do with the amyloid, which is deposited much more vigorously in the brain. So there is a lot that is beginning to evolve in this field.
Also, I think one of the intriguing things is the toxicity of the AL and whether just infiltration on the TTR, which is an interesting, both from its echo manifestation as well as from the gadolinium, as well as from the pathology.
Well, it's a paradox. Why the AL amyloid is so much devastating into the heart, when in fact, when you look by MRI and by any technology, is much less dense than the TTR amyloid. That's one of the issues, and I think you are completely correct. There is a toxicity issue there that has nothing to do with what you see as a deposit.
Jim, if the patient is going to get started on a treatment plan, and we'll discuss that with Peter in a moment, can echo follow a progress? Do you see regression by echo? Do you see improvement in the strain pattern, or echo is good for the initial diagnosis, but then limited value afterwards?
I don't know of good data that suggests that we see a lot of change with treatment. Of course, it depends on what treatment we're talking about. Are we talking about, curing the myeloma with a stem cell transplant or something like that? Or are we doing a liver transplant? Or are we just treating with diuretics? I think, you can have some guidance from Dr. Pfister and I were talking about looking at E over E prime in that it's not a perfect test by any means, but if you can lower the E wave and raise the A wave a little bit, you've probably done something good for that patient. But in terms of monitoring these more advanced therapies, I'm would hope that there would be some reversal of these findings versus just slowing their progression there. But I'd be interested in hearing, from Sean as to what you think the role of these very aggressive therapies that some places are now using quite, freely, but others not.
So we can go a little bit into the therapy. So for AL amyloid, melphalan and dexamethasone are sort of the cornerstones of therapy. Pretty good response. Thalidomide and some of the congeners of thalidomide are a backup agent, but I think the biggest effect that we've seen is success with bortezomib, which has induced remissions in greater numbers of patients with primary amyloidosis, that associated with either myeloma or a plasma cell dyscrasia or even just low levels of plasma cells. And listening to your discussion right now is just beginning to think that, that the disease is being transformed in front of us as more and more people are going to survive with AL amyloid, with these successive treatments. It's going to give us an opportunity to study the cardiac effects longitudinally, something that I really hadn't thought about. We have this woman who I was mentioning before who's listed for transplant, and I'm watching her now for 2 years, and no significant change in her cardiac function, but it might be worthwhile going back, and since we do have the echoes, we can do longitudinal strain and see what we can learn from that. That might also be a project for a young fellow or a resident, which is to go back and look at some of these echoes or link up with our myeloma center, which is really one of the largest now in the country, and start following some of these folks longitudinally and see what happens to their cardiac function.
Mo, do you want to talk about following the cardiac biomarkers?
So just in terms of following up the response to treatment, there's at least multiple trials showing in terms of prognostication. Mayo Clinic score and the revised Mayo Clinic help you with prognostication, and in AL amyloidosis, at least several chemotherapy regimens and terminal pro and BMP, like the way that the graph and trends down, and at least in a couple of trials I remember looking, when it decreases dramatically, it's a sign of response to therapy and increased survival in comparison to people who did not show changes in the cardiac biomarker. BMP more than troponin, although some showed troponin, but definitely pro BMP. Some people look at free light chains also, but from a cardiac perspective, BMPs are the major ones.
So, Peter, the treatment depends upon the type of amyloid. And tell us a little bit about when you make the diagnosis of AL, when it's made specifically, what's the life expectancy of the patient once you've made and confirmed AL?
Well, the answer is that the life expectancy of patients with AL has gotten progressively better over the years. The biggest registry comes from the Mayo Clinic, and if you go back to the 1940s, there was maybe a 4 or 5 month survival overall. And in the most recent series, we're up to at least 2 to 3 years in terms of survival.
How's it, with what treatment?
But it breaks down very much according to whether the heart is involved or not. The patients who have cardiac involvement have a much worse prognosis than the patients who have other systems. So this is the major therapeutic challenge with AL, is how to treat the heart, because the patients who have significant heart disease have been precluded from transplant for a long, long time. They do not tolerate the chemotherapy very well, and so there is a definite need to do better. One point I want to make is that there are 2 components to the therapy of amyloid diseases. One is getting the amyloid out, but the other is the functional abnormality, which is what I think you were referring to before. So you will see patients who will have prolonged amyloid deposition. It will not go anywhere, but you may see a dramatic change in terms of the function. And the most interesting studies that are going on right now are looking at a monoclonal immunoglobulin light chain that is 2 light chain, and they are using this to try to clear the amyloid, but it also reacts with these aggregate forms of light chain. And what they're noticing in their study, which is really a very big study now, 2 studies that are going on, is that the biomarkers go down. And they go down very, very quickly. So you stop and you see the NT-proBNP and the troponins go down. But what we haven't seen yet is what happens to the amyloid. And there may be 2 very discordant issues, that you can see a functional improvement, but the deposition is still there over time.
So at what point with AL do you start treatment? And then just take us through, Sean mentioned, there's a chemotherapy regimen, and then there's autologous stem cell transplant as part of the plan, followed by, chemotherapy again. When, upon the diagnosis, if you have a positive echo, positive MR, positive tissue, you say, okay, the person is mildly symptomatic or asymptomatic, but comes because of incidental finding of an abnormal echo or low voltage on the EKG, but is relatively asymptomatic. Is that the time to start therapy?
So I'm probably not the best person to answer it. If it was 30 years ago, I would have been, because I was treating these patients, but we're very fortunate in having a very active hematology oncology program in myeloma, and they have several protocols that they follow, but the usual protocols are to combine melphalan or some substitute for melphalan with high-dose dexamethasone. High-dose dexamethasone is the mainstay of treatment. The reason for being interested in bortezomib and the proteasome inhibitors is because they work quickly. But they do have cardiotoxicity, so you have to be very careful about how you use it. So that's what most of these patients would be. And then in terms of whether they're eligible for autologous stem cell, there's a whole list of specific criteria that have been developed by the major centers in the world that work on this, and patients are stratified. And it's really only maybe 20% of patients who are really eligible for stem cell transplant.
Jim, are there certain echo markers which would negate the patient as a transplant candidate, saying that there's so much cardiac involvement that they won't survive the treatment plan?
Well, I think it sort of falls under the general heading of common sense. If generally, we sort of started out with a discussion of HFpEF, so heart failure with preserved ejection fraction. If you have an amyloid patient who has a non-preserved ejection fraction, that's a very bad indicator there, and my guess is they would not tolerate the aggressive therapy at all there. Obviously, I think some of your degree of aggressiveness depends on the age of the patient, and my 94-year-old guy that I read last week, it's going to be let's make you comfortable, and we'll hope that we can play this out as long as we can here. But is there a role for, like in the transthyretin, for doing liver transplants or heart transplants or combinations, or how aggressive do you get in some of these patients?
So there's a differential outcomes after transplant depending on what type of amyloid you have. So the AL amyloids generally do not do well. This is a multi-system disorder. Some things that would portend a poor outcome prior to transplant in the setting of AL amyloid would be, as you mentioned, systolic dysfunction, a very low pulse pressure, hypotension, recurrent syncope. We heard that in one of the case presentations tonight. And then evidence of multi-system involvement. So pleural effusions would be really bad, GI involvement, particularly with gastric motility disorders. Any autonomic disruption, autonomic dysfunction, and then the amyloid angiopathy. So, you can transplant the heart, but you're not going to fix all those other systems. And so those individuals tend not to do well after surgery. If you look at the 1-year survival, it's about 60%, being generous. in highly selected patients with AL amyloid who go for cardiac transplantation, as opposed to 90% one-year survival for the general population. And that's why there are only now a few Intrepid centers which are still doing amyloid and doing AL amyloid, and talking to them, their colleagues are trying to get their other colleagues to stop doing them because the survival is so poor. Transthyretin amyloid, a completely different story. One-year survival, very, very similar to a general population, and I think in those individuals it is an option. We used to consider doing heart and liver transplantation, but now we consider just doing heart alone, keeping the liver in there, because the transplanted heart is going to have plenty of time before it's going to develop amyloid deposition in that transplanted organ, so you can go 10 or 20 years before it becomes a problem.
Mo, have you followed a patient with amyloid?
Saw them in the unit, didn't follow them on my own. They're probably Dr. Pinney's patient, Dr. Fuster's.
Well, I think just as a general statement, we're seeing patients living longer with their disease, and I think that we're going to see more patients with, amyloidosis, whether it's the transthyretin type, the senile, so-called, senile type that we're seeing as an incidental, or is it going to be AL where maybe the light chains are actually a toxin? So maybe we can just have one closing statement from each of us as we go down the panel. Dr. Fuster?
I think we need to understand the molecular mechanisms of amyloid. And once we understand them, I think it's going to be a significant movement. For example, can we block the gene that manufactures TTR? Or can we prevent the aggregation of the splitted proteins that cause the filaments of amyloid? Actually, green tea, I don't know if you heard that there are studies that green tea could do that. I don't know how good they are, but so I think we have to understand there is a molecule, there is a protein, the protein splits, can you prevent the splitting? And if it splits, can you prevent the aggregation? And I think this is where the field is really going at the present time, is more at the molecular level, particularly on the TTR, the AL, obviously you have to treat the way that has been described. I think it's an exciting field, and I'm saying this for the following reason, because a similar approach is being taken now with muscular dystrophies. The muscular dystrophies are mutations also, but have similar problem, very rapid diseases. The molecular bases are better understood, and all the different treatments that have been discussed today here at the genetic level and so forth are beginning to evolve. So I feel rather optimistic that in the next 10 years, some of these devastating diseases that we didn't understand the molecular basis, I think there will be tools that will be able to focus the specific aspects of this molecular biology.
Just to follow up on that, Dr. Gorovic, the diflunisal and TTR and green tea, should we all be drinking green tea?
And doxycycline and ursodeoxycholate and a few other things.
And you want to mention about diflunisal and...
Well, the point I think that we're all making is that as we, and this is the most gratifying thing for me, I lived long enough to see this go into translational. And so we are now seeing a plethora of translational approaches. We are involved in 2 studies here at Mount Sinai in which we are inhibiting the gene. One was using a silencing RNA, and the other is using an antisense oligonucleotide. And we are talking about doing the same thing for the cardiomyopathy. And the green tea story is a fascinating story because it's also being used for Alzheimer's disease, so it may be a sort of a generic thing. The doxycycline has nothing to do with the fact that it's an antibiotic. And we in rheumatology have known that for years. The doxycycline does a lot of other things. And so we're going to see a lot more. There are 2 antibodies out there. One is this monoclonal anti-light chain, which is going to be very exciting for the cardiac amyloid patients who have AL. And the other is an antibody to something called P component, which is being used as a therapeutic for every type of amyloid because this particular protein co-deposits. So I couldn't agree more. I think over the next 10 years, we're going to see A lot of very interesting stuff. I hope I'm still around to see it. It's very interesting.
Mo?
So just based on what I learned, I would say, is that we should look at amyloid not as just amyloid. What kind of amyloid? It's more, they're not just one disease. They're different diseases, have different precursors, and they have different prognosis, course, and presentation. And echo and EKG are kind of, with clinical presentation, are the current state, but echo with strain imaging, and particularly nuclear imaging, which we didn't get to talk much about, but has a lot of future that eventually will play an important role in the diagnostic approach to it. After, of course, echo and MRI. So echo, strain, MRI, and nuclear imaging can help you kind of confirm the diagnosis and in a way differentiate which type, which is kind of have a different mechanism, which eventually will affect the prognosis and the choice of treatment. And there are many exciting things going on, whether liver transplantation, combined, sequential heart and stem cell in certain AL patients. But the other interesting part, as Dr. Fuster was talking about, is kind of personalized medicine, where they kind of, based on which gene mutation you have and which disease, they target certain things, whether tafidamide silencing certain gene expression, or other drugs that kind of in phase 3 trials now, which is exciting kind of. So it's an old disease that had very bad prognosis in the past, still has, especially AL, but it's improving, and there's many options are there, and kind of, in a way, a good outlook for the patient, hopefully, in a certain number of years, hopefully, or lifetime, hopefully.
Go look for it. It's out there. It's oftentimes overlooked because we don't think about it, and the diagnosis is made too late. So 4% of African American men are carriers for the genetic mutation for the isoleucine, or the Val122 isoleucine mutation. So go look for it. It's there. Lots of excitement coming, both in terms of diagnosis and management, so stay tuned.
Jim?
Yeah, I would just play off of that by saying I think that that there are clues on the echo early on, and there are undoubtedly cases that are too early to have the full-blown apical sparing. Apex is spared, but the base is not severely affected yet. There's obviously cases that are too advanced and basically everything is burned out. But I think if in your echo lab you can get in the habit of doing strain mapping on everyone with thickened walls, you will pick out a lot of these patients. It may not be the full-blown cherry on top of the ice cream cone, but there will be something that says that apex is a little better off than the rest of the heart, and that can be a clue that'll start the diagnostic workup there.
Peter? Any other comment?
Anything additional?
No.
Well, we didn't mention that we routinely do genetic testing these days, and I suspect that we're going to do better as time goes by with the genetic testing. We were the first group to describe the ILU-122 substitution, and it's an example of the type of thing that we can do more and more to evaluate these patients.
Steve?
Just that cardiac MRI can provide a lot of information in regards to diagnosis for cardiac involvement of amyloid. As I talked about earlier with the contrast, it can provide prognosis. But even without contrast, we can find that amyloid deposition can prolong T1 relaxation times and make it difficult for us to do the normal things that we do to image the heart. And so that gives us a suspicion for that. And then I wanted to give a couple of words about the nuclear, since it was brought up a couple of times. So this technetium pyrophosphate, originally kind of observed in the 1970s and 1980s by Dr. Falk. He published on that back in the 80s. It's a tracer that was used for bone imaging in nuclear medicine. And they found, coincidentally, that in certain patients, there was a high uptake of this technetium pyrophosphate in the heart. And subsequent studies, including one that came out a couple of years ago from Columbia, showed that sensitivity specificity of 97 and 100%, differentiating between AL and TTR. Of course, it was a small trial, but it's very promising, as Mohammed said. And then the technetium DPD, which is used fairly frequently in Europe, is not available here. So the one that we would use here would be the technetium pyrophosphate.
Excellent. Thanks. Mark? I don't know.
Just anticoagulate and do your best to keep them in normal rhythm. I think that's, from our perspective, that's the best you can do for the patients, actually.
I think what the panel is emphasizing, we see these patients, we don't recognize them, and hopefully after tonight people will recognize, at least be suspicious of these patients for doing additional, more advanced testing, because I think the sooner you pick them up and the earlier you pick them up, the better chance we have of getting a healthier patient. Any questions from the, just go to the mic, go to the mic.
Actually, I have a question for anybody who has an answer to me. The more we look for it, the more we find it. And so I managed to find a bunch of it. Now the question is, what do you do about it? So the AL is kind of straightforward. It's turning it on helps. The AL is, there's a direction. I'm wondering how many of you are actually using difluzinol? How many are using doxycycline? When do you start them? Or is it something we just talk about and wait for further studies?
I start diflunisal only because I don't have access to tafamidis or rasuveran, which are the two compounds which are being studied right now. Tafamidis is a stabilizer, so it prevents the amyloid, the transthyretin amyloid from being deposited. Rasuveran is a microRNA gene silencer that shuts off production. We have a couple partnerships, one with GSK, the other with Alnylam to start some clinical trials here in the ATTR patients. But in the absence of having access to a clinical trial, I'll use diflunisal and mixed results. It's hard to know what I'm comparing it to, so those individuals who lived for a few years on diflunisal, I declare that success. The ones who had GI bleeding and I had to stop it because of just bad peptic ulcer disease, I consider those failures. And I have more successes than failures, but whether I can prove that I've actually done anything to improve survival, that I can't prove.
Any other questions? Again, thank you very much. Thank you, Dr. Thomas. Thank you.